Thank you for joining us today for the first of 3 webinars in our Talking Telehealth series. Telehealth Technicalities, Do's and Don'ts in the COVID-19 world, our first of 3. I'm Sean McMillan, Executive Director of First Step House and the 2020-2021 Chair of the University of Utah College of Social Work's Community Advisory Board, the CAB. The idea for these webinars originated in a virtual board meeting in April, as my fellow board members and I shared our experiences of launching into telehealth to meet client need in the COVID-19 crisis in our respective settings. We recognize that our organizations and many others faced a fire, ready, aim approach to telehealth in the pandemic. We had learned a lot, and we still had a lot of questions. Board members, supported by the College of Social Work Dean Martell Teasley, Professor Brad Lindahl, and others in the college, began talking with community partners about lessons learned and long-term goals for telehealth therapy, including where do we go from here and where can we go? Board members supported, the result is this, the Talking Health webinar series. We intend this series to be a conversation with community partners around all of these issues. We do not presume to be a definitive answer to telehealth care, but we do hope to share our insights, inspire conversations, and explore what the future might hold. The more voices involved in this journey, the better. So thank you for joining us. Our moderator today is Tamara Atala, MBA, LCSW. Tamara is Pediatric Behavioral Health Community Services Director at Intermountain Healthcare's Primary Children's Hospital and a fellow College of Social Work Community Advisory Board member. He will introduce our panelists and facilitate the online discussion. Tamara, take it away.
Sean, thank you so much. I appreciate it. And I am really excited about this opportunity and the interest that's been presented. So with that, I want to start with just some real quick housekeeping items. What you already realize that we've done is we've muted all of you. However, we really hope to engage. And as Sean indicated, this is really designed to be a conversation. And our panelists today, absolutely have experience in this area and have had the opportunity to learn. And so we wanted this to really be the opportunity to have not only a conversation, but an opportunity to understand what your experiences have been like. So we ask you to ask questions, present comments. I have a couple individuals that are going to be helping me kind of curate a lot of the comments and hopefully push that back out to the panelists for some questions. We will start with a little bit of content just to get the ball rolling, but I'll be jumping in and adding comments that you've presented along the way. In addition to that, I wanted to make sure that as we'll wrap up, we'll talk a little bit more about the CEU's components of it, and then also we'd like to learn about how useful this experience has been for you. So more to come on that. With that in mind, let me go ahead and start and introduce Jared Ferguson, who will kind of kick us off. So take it away, Jared.
Thank you, Tamara, and everybody, thanks for joining us today. My name is Jared Ferguson. I'm the clinical director at First Step House, a local nonprofit substance use disorder treatment center. And prior to coming to a career in social work, had a career in information technology. So the topic of today is technology as it relates to the provision of helping services and some things we can do to stay safe is something that is important to me in my role as clinical director, but also just as kind of a closet geek. So hoping to start with a little bit of content today to kind of give everybody the lay of the land of like how we kind of got here as a profession, particularly with regard to privacy law and some of the things that have recently changed. And hopefully that will lay the groundwork for a discussion about implementation of telehealth and some of the things that we've had success with, as well as some of the challenges that we faced. So with that, I'm going to go ahead and share my screen here and just get through a couple of quick slides on kind of like health law history. And starting here real fast, just kind of give you an overview of the 6 or 7 things I'm going to touch on. 42 CFR, HIPAA, the HITECH law, the recent CARES Act, and then a couple of bullet points on just laws versus technology, and then ethical considerations for social workers. And again, hopefully giving a little historical context that will create some potential fodder for conversation. So as Tamara said, we really want this to be an interactive experience. And so please know that this is not going to be death by PowerPoint. This will be really short-lived, but hopefully it does give some context to, kind of what brought this conversation to pass. So quick overview of 42 CFR for most of you. I'm assuming most people are familiar with this law. 42 CFR refers to the Code of Federal Regulations, Title 42, with regard to public health. It's actually coded into law in 1973, and it established privacy provisions for entities that hold themselves out as treatment providers. It also established privacy safeguards for people who are receiving substance use disorder treatment. And so today, when we talk about, law enforcement access to treatment centers or those kinds of things, court access to records, 42 CFR is the law that governs a lot of that. Later on, we have HIPAA, not HIPAA. It's the Health Information Portability and Accountability Act. It was signed into law by President Bill Clinton in 1996. It establishes the concept of protected health information, and it set administrative, technical, and physical safeguards for that protected health information. So you go to your dentist, and your dentist gives you this form that says, hey, this is how we use your information. That's all a result of HIPAA. It does set forth guidelines surrounding the use and sharing of protected health information, particularly for medical professionals. And it also set guidelines for informing consumers about the use of that PHI, as I just mentioned. A little bit later on, 2009, we get the HITECH Act, which is Health Information Technology for Economic and Clinical Health Act. I completely forgot about that acronym until I had to look this up. Signed into law in 2009 by President Obama. And it established incentives for medical providers to move to electronic medical records by 2015. It tightened up some HIPAA provisions, and it actually created tougher penalties for people who are found to be in violation of HIPAA. And then it revised the permitted uses and disclosures of personal or protected health information, and established some very clear guidelines on the revocation of previously authorized consents. So a person under the HITECH Act can actually revoke consent a little bit more easily than they could previously. And importantly, it established some limitations for treatment providers, medical professionals, in using clients for marketing purposes. That was something that was starting to happen more and more. So the HITECH Act actually covers that. Most recently, we hit into the Coronavirus Aid, Relief, and Economic Security Act, just recently signed into law by President Trump. And this one had some heavy hitting consequences, because it had it created some major revisions to 42 CFR, which I previously covered. Initially, written consent can be carried forward to other organizations that are covered under Part 2 and as allowed by HIPAA. So, long story short, a person signs a consent at the first of substance use disorder treatment, and that consent can actually be carried forth into other treatment episodes. And then it changes information that can be redisclosed according to HIPAA. So health providers now have access to information with less need for consent than they did before. And again, primarily because of the health considerations of COVID. Whereas the HITECH Act allowed people to revoke their previously consented authorizations verbally, the CARES Act actually goes back and states that the revocation must be done in writing. And so there's some change there. And de-identified information can be used to help public health authorities track, pandemic situations. And importantly, it moved oversight of HIPAA law to the Office of Civil Rights. We've joked for a long time at First Step House about the HIPAA police, and the HIPAA police is now the Office of Civil Rights. And then finally, records, is very clear in the CARES Act that records cannot be used under civil, criminal, administrative investigations or proceedings without a proper court order or consent. So it really kind of sets some things into motion there, or at least codified them. So moving on real quick, laws and technology. Technology has outpaced laws. I mean, since the 1990s, the development of tech has outpaced the laws governing tech. And an example that we can use here is encryption. many of the applications and services that we use every day are technically not HIPAA compliant, but they actually use higher security standards than things that are. And an example is common services from Apple, which actually create and establish a secured connection between two parties and then actually throw away the key. So, Apple couldn't go in and read my iMessages, for instance. There's an open source messaging application called Signal that uses a very, very high degree of security. It's an open source application, which means anybody can go actually review the code and determine whether or not it's flawed. And these applications create a very, very high standard of security. Now that said, when speaking about encryption specifically, not all encryption is equal. There are different ways to do it. An entity could say create a backdoor that would make a platform insecure, and we've seen some recent instances of that even since COVID. And the platform we're using today, Zoom, came under fire early on because of some oversights in its safeguards. So additionally, HIPAA requires what can be costly business associate contracts, and so entities that create very secure platforms may not necessarily go to the length of becoming HIPAA compliant because of cost or other reasons. The interesting thing about the business associate contracts is that they require but do not define encryption standards. So, there's a complete lack of standardization in all of this. Now, lastly here, thinking about ethical considerations as social workers, some of you may be familiar with the Standards for Technology and Social Work Practice that was put out in 2015 by the NASW. After a couple of years of writing and research, the NASW came forth and really basically said that social workers have a responsibility to stay apprised of technology and technology-related issues, and ensuring that we are doing everything we can as practitioners to keep these safeguards in place to ensure that our client data is safe and it's not being inappropriately exposed. This document sets standards for the delivery of services. It even sets some standards with regard to personal conduct. So section 2.11 covers the use of personal technology when doing business, so like using your cell phone to call clients. It sets standards and guidelines for the storing, gathering, and management of protected health information. And importantly, it also set guidelines for the use of technology in clinical supervision. So there's some important factors here that we as social workers have actually been charged with in relation to this issue. So lastly, kind of talking point here, as far as an ethical consideration for social workers is access. Sometimes the people that we serve, may not necessarily have the means to, have an iPhone that they can chat with their provider with, or maybe they're in a household with 6 kids and 1 computer. I mean, these are some things that we've seen, in recent times that have become, highlight issues for our profession. Ultimately, the takeaway I hope that you're getting here is that even in a COVID world, as social workers, it's still our job to protect our clients' health information. So with that, Tamara, I'll turn it back to you.
Great. Thank you, Jared. I appreciate that. And really I really appreciate kind of that background that really kind of sets the stage for how do we immediately end up ramping up services in the telehealth space. So I think, if memory serves me right, Jared, do we want to have Jason or Christina, I can't recall which, kind of share their experience? Shall we start with Jason, or?
Yeah, either or is fine, I think.
Great. Jason, do you want to introduce yourself and share us a little bit about your perspective?
Sure. So my name is Jason Cox. I'm one of the operations managers with Intermountain Healthcare. I've been on our system telehealth team for about 5 years. And my role really encompasses, services from inception, building a business case, all the way through execution and training. And so I'll just quickly share a little bit about our experience over the past couple of months with COVID coming into play. Over the past few years, we've done a lot of work both on the acute care and direct-to-consumer side, providing telehealth services to our communities. And, coming into a COVID environment and thinking about how we might protect our providers and our patients, and how we would address something as simple as clinic operations, and now we're in a COVID environment, and our patients are not able to come into the clinic, and having clinics shut down. And so we've been doing quite a bit of work setting up what we call an alternative video visit solution. So with the regulations being loosened a bit on the technology, allowing FaceTime, Google Duo, Doximity, a few of those technology platforms, we set out to really rapidly deploy that out so that our providers could continue to see their patients. All the while with a strategy, a longer-term strategy of how do we move our providers to a more secure platform. And so, really we've been doing those in parallel. It's been a lot of work by a lot of people that have had to come together and really broaden kind of our thinking in terms of some of the rigors and structures that you have in a large organization like Intermountain Healthcare, and some of the bureaucracies, I would call them. We've had to kind of, take down those walls and work quickly together to be able to deploy something pretty rapidly. And so we're still in a moving environment. I guess one other thing I'll quickly share about our experience on the inpatient side, we've had to ramp up quickly how we're going to provide telehealth services into our inpatient rooms that may be seeing COVID patients, they may be an overflow unit, and how we can connect virtually into those rooms. And so we have a number of strategies that we've deployed there as well pretty rapidly. We've had a lot of lessons learned, but really I think being flexible and adaptable and coming together as a team has really kind of helped us. So.
Thank you. I appreciate that, Jason. And along the way, I think as we're kind of getting used to some of the questions and comments, I think a great question just came up related, and this was back, Jared, a comment that you had made related to being conscientious about access as it relates to technology. And a question was raised, how is your organization managed, or maybe others as well, how's your organization managed kind of mitigating that barrier for low and no income clients? And then there was another question that was asked related to, in this kind of platforms, or these platforms, how are you all trying to manage group therapy?
Christina, I'd love for you to take a stab at a couple of those questions, and I think I might be able to chime in as well. And I'd love for Stacy to share her thoughts there as well.
Excellent. I am Christina Smith. I'm a licensed clinical social worker and the Chief Operating Officer for Odyssey House. Odyssey House is a medium-sized nonprofit focusing on substance use disorder treatment services and mental health treatment services to a variety of individuals. We have large residential programs in addition to everything all the way down to school-based services. And so we've encountered a lot of different types of challenges in terms of moving things virtually, particularly for our outpatient clients and for our medical clinic patients. So we had been doing a lot of planning over, back into January, started talking about what types of things would need to come online, knowing that eventually we would be faced with the pandemic here. And in spite of all of the preparation, it was really flipping the switch over like one day. So a 9 o'clock call in the morning to 5 o'clock that evening, we had outpatient services up on video platform. And it took us about a week to get all of our outpatient clients kind of oriented to coming up and showing up on their services in some range of being timely. We also encountered a lot of access issues because we work in many cases with some very disadvantaged individuals who either didn't have the financial ability to have their own technology resource, or were looking at having lost their jobs either at that point or had lost employment since then. And so we spent a whole lot of money buying tablets for people, and making sure that we had tablets that our clients could check out, that we were using an interface that people could connect to regardless of the type of smartphone they had, and making sure that we had those resources available not only and at the outpatient level, but that we were bringing some of those resources into residential settings as well. So we have had, we serve about 400 individuals in residential care at any given time. And through this process have had to isolate and shelter in place with several of our individuals, but also knew that substance use disorder treatment is a critical service and a medically necessary service. And so just because we were waiting on testing results and those types of things didn't mean that their mental health treatment could stop. And so making sure that we had access there within our residential settings so that they could tune in, meet with their individual therapists, negotiate group. To speak to the group question, we had to set some pretty specific norms, particularly in our outpatient settings where we had people at home with family members, and did a lot of expectation setting around having a quiet private space, and protocols on what the group facilitator would do if there was concern about the privacy and someone else had come into the room or those types of things. And that took about a week for our team, or for our clients to get used to as well, but they really acclimated well to that, did a really nice job at holding each other accountable if they were concerned that someone was distracted or not focused on what needed to be happening in the group and that sort of thing. So I think I kind of spoke very broadly about a lot of different things there, but I hope that kind of addresses some of those questions, and the process that we went through in terms of standing up these types of services. And to speak on the medical side of things, we've moved about 75% of our office visits to telehealth. And so we're doing prescribing and medication follow-up and standard visits that way. It's really, the individuals who need Vivitrol injections and some of those types of things where we've got those patients still coming into our clinic.
Okay, so if you're all right, I'll continue on what
yeah.
our perspective is. I'm Stacy, and I'm the office manager for Fort Healing Center. And we have 15 providers that are full and part-time, and we focus on outpatient mental health counseling. So we do medication management, we do group therapy, individual therapy, family counseling. We focus a lot on trauma treatment, depression, anxiety, a lot of the counseling for those things. We also kind of were, like Christina, looking in advance and seeing what was happening and starting to make plans, but likewise, it was a fast transition. It was coming up really quickly where we had to actually make the transition. We had been largely doing in-person appointments, and we went within a week to doing 100% telehealth for all of our clients. And so, but we had been able to make the decision on what kind of platform would be the best for our use, for us, for our clients, based off of ease of use, cost effective, HIPAA compliancy. And so we made the decisions on that. And then for those clients, there were some issues. You had to take it by a case-by-case basis. Did they have privacy at home? Were they able to even have a telehealth appointment in a private location? Were they able to have video technology for telehealth, or did they have to look for another form that was still HIPAA compliant that would allow them to have a session? For the few who weren't, we were able to take it case by case to see what were their needs. Did we need to find them an in-person appointment somewhere else and refer them? And so, and we took care of any needs that they had. and continue to check in on those clients who have elected to wait and still want to come in person, but have decided not to continue with telehealth. So we do continue to look out for them because their needs are the most important thing at this point in time. As far as addressing the needs of those who are high at risk, who are in like the low income range, we implemented kind of a COVID relief program in-house where we didn't have a sliding scale before. We now, for those who were directly impacted by the COVID-19 pandemic, we implemented one to be able to help those who were economically disadvantaged because of COVID-19, whether it was cut hours at work, loss of job, anything like that. So we've had people take advantage of that because of their needs, and so we've been able to hopefully mitigate some of their concerns, still give them the mental health that they need, the mental health treatment without being a burden upon them. So.
I'll just add real quick to that. I mean, on top of, what's already been shared, I mean, First Step House did a lot of the same things. I mean, we went in some cases, in many cases actually, back to, POTS, plain old telephone service. We actually purchased a number of burner phones for our folks, as Christina mentioned, who were coming in that may not have had means. And so we could actually have contact between an offsite clinician and somebody, who's maybe just coming into treatment, tablets, much the same. And then we also moved clinically to what we've kind of called low intensity, high frequency contact. And so we were doing, like daily check-ins from clinician to client, and then sometimes semi-weekly full sessions. And so in addition to kind of like regularly just checking in on everybody, like, how are you doing? We were then having folks, do at least 2 weekly sessions individually with their therapists as well. And we actually found quite a bit of success with that model so far. I mean, just people seem to be responding very well to just this increased frequency of contact, even though it's not like, like a full session, sometimes even just, 10, 12 minutes on the phone. Seems to really provide an adequate level of support for people.
So I'm almost hearing, some of the creative approaches that trying to really be thoughtful about how does that interface change the traditional treatment modality.
Mm-hmm.
There were some questions I thought that were really interesting specifically related to group therapy. I mean, you all spoke a little bit to this. The specific question was really in terms of how successful was the group engagement? So this is kind of a two-part question. The first part of this is, how successful was the engagement, considering you're trying to manage a lot of different people, similarly to what we're doing right now on this call, but also managing kind of the risks related to PHI that Jared had indicated earlier. Any thoughts about how you all have navigated that?
Well, I'll chip in here real fast. I mean, our group services were put on temporary hiatus, March 16, when we decided to send everybody home. We needed to formulate a plan for how we were going to do this, and it took us a good couple of weeks to really get things rolling. We started off with our residential centers by setting up laptops plugged into, televisions where we could get, kind of a communal setting going. And it was pretty hodgepodge right at first. We would have people come up to the laptop and, share, ask the question, whatever. And it was really a big learning experience for the clinicians, and the clients, despite the awkwardness of it, adjusted, as Christina said, like really well, like right up front. And group services were some of the things that they were, almost from the get-go, requesting like more and more of. And there were some logistical obstacles. In the residential facilities, it was a lot easier for us to accommodate that than it was, as was mentioned, in the outpatient setting, where, we had some people that, had, gotten together that were sharing a cell phone. We had people who had a data plan, but not Wi-Fi, and they were unlimited data, and then their data ran out. And it was just like dealing with constant contingencies. And I think that was sort of like the main thing was just encouraging the clinical staff to maintain flexibility and to just find a way to proceed forward with the group and the group content, even during those, technical disruptions, and we've certainly seen that, in all of the meetings that we've been a part of. The new world when, you've got stuff going on in the background, and doing our best to, provide those secure and safe treatment environments, and also being, cognizant of the fact that for some of the folks we serve, that's not always a possibility.
I think one of our therapists also had mentioned she had been a little apprehensive about taking her group onto online, and she was able to make some modifications to her group and how she was approaching her DBT course. And she actually remarked like it was doing really well. She was saying it was some of the best sessions as well of doing a group, even online. So it went from being a little bit concerned to actually being relieved. This is working out, it's helping them, it's still useful. So that was the perspective I was getting back from some of my clinicians.
Yeah, and this is our experience has been, there definitely is an art form to be able to facilitate a group in that type of setting. And so, we do a lot of lessons learned and tele-etiquette and telepresence, kind of education and some simulations with our providers, after they've been facilitating a group session and even prior to really kind of increase their comfort level with being able to facilitate a group over virtual technology, and that seems to help quite a bit. But truly, there is an art form to it for sure.
Those are great comments, and really creativity. I think that really requires us to kind of think about things differently, and honestly sort of like learn on the fly. A lot of this is happening, and I'm really excited. Some of the comments were really wonderful segues into our subsequent webinars. There was a great question, I think, from Barbara talking about, what are the guidelines related with children, for example, and adolescents. And actually, we're going to have a panelist next week at the same time and place from Safe and Healthy Families that actually have done a lot of work in this area. And I'm excited for them to share the learnings that they've had, in addition to some of the training that they had done prior to COVID, and I'm excited for what they're going to share as well at that time. And then also some follow-up conversations. And I think we're all sort of thinking about this, and I'll start it kind of at the top and kind of work our way down. There's, in terms of, particularly with working with the substance use, the populations that are in substance use disorder treatment, and the intersection between that and legal issues. How are you all navigating that component of it as you're trying to, as treatment is obviously very, intersects a great deal with probation and that group as well?
Well, First Step has had a court liaison for the better part of the last few, three plus years now. And that person has continued on in that capacity, interfacing with various, court entities. They're responsible for, the reporting processes that, we're obligated to take part in. And, that, really actually kind of remained super unchanged, except for the fact that it was happening virtually. I mean, court, appearances were canceled, and that required, a high degree of liaising, between the staff member and, the various legal entities. I think the big challenge that we faced was, folks, POs, who wanted to come on site. And we weren't allowing, members of the public to come in and do check-ins. And so there was sort of a, gotta trust me on this, your person's here and they're doing well. I'm sorry you can't see them right now. So there was a little bit of, kind of relational navigation there too. And some officers were great and they were really understanding of it. And some of them were really insistent that they wanted to see their people. And so, the liaising, I think, that we had set in place, was very helpful. It was able to carry forth just in a different, through a different medium. And it really was just kind of dealing with some of those relational contingencies with our, our justice stakeholders, and helping them understand, we were trying to really preserve the safety of the environment. So that was, I think, probably the biggest change at First Step House.
Great, thanks, Jared. I appreciate it. Christina?
I think we ran into a lot of those same situations, and had a lot of those same conversations and with our partners. The other thing that really significantly changed for us is how we do urinalysis drug testing. We work with a third-party company, and so it was a lot of coordination with them to make sure that there wasn't unnecessary or additional exposure from either direction, that we were keeping their collectors safe and that their collectors were keeping us safe. We made changes about, where we may have had either internal staff members or the collection staff, whereas they may have collected samples at several different settings within our organization, we limited them to single locations, and then we had to change the degree of observation on that testing. And so that was one of those things that I really hadn't, until we were in it, I hadn't really thought about all of the consequences and how, that can be a pretty intimate experience, and you're kind of within someone's 6-foot bubble. And so making sure that we were making appropriate modifications there so that we had good testing fidelity and we could share that with our criminal justice partners, but also so that our clients were being kept safe, because our client and staff safety is definitely our paramount concern. So.
I appreciate that, Christina. Yeah, it's again, trying to navigate these things as you're working with different parts of supply chain and different parts of the needed partners as you're delivering care. That makes a lot of sense, and it sounds like we're still kind of learning that process as well. This is I love this kind of question. There's a couple questions that came up about this, and I'm curious to see if you guys have at least addressed this, or this has sort of come up, and it's related to, and I think the whole healthcare system is really struggling with this as well, and that is how are we transitioning so rapidly into billing in this new space? There was some comments earlier brought up about, hey, we're checking in with patients. Is that actually, or using the phone, is actually a billable service that you're delivering? I mean, can that be billed? That's kind of part one in kind of a zoomed in sort of way, but then like more broadly, how are you managing like billing overall and being able to receive payment for the services that are rendered?
That's a really good question. We had there were some adjustments made early on to some of the major billing codes that we use that allowed for a modifier of telehealth to be applied. And so those 10-12-minute calls that I was talking about earlier, as long as they met the structural minimums to be used, we are using them and we are being paid for them. The residential settings obviously are different than the outpatient settings, because there's obviously a component to like a living rate that gets paid that's separate from the how things are done typically in an outpatient setting. And I know different organizations do that differently, but billing has been challenging because we're not doing group services on the scale that we used to. But with the modifiers that were allowed early on, by I believe it was the state Medicaid office, we are able to make annotation that this was a virtual conversation or a virtual group, or something within the encounter narrative that have given us leeway to continue to bill for those telehealth services, whereas that was not previously allowed. So that was something that happened pretty early on. That allowed us to carry forth, and I would assume that for Stacy and Christina, it's probably similar.
Yeah, so we did notice at the very beginning, the insurance companies were saying we want these modifiers for this telehealth, and then a few of them changed their mind. So we had to start keeping track of which insurance companies wanted which type of modifiers, because they're not across the board the same, and that's okay. We just keep track of it and bill as appropriate as to what they've asked us to bill for this particular service. We do have, as far as collecting payments, we do have our front office staff calling in prior to the appointments to let them know what the charge would be expected to pay. Many of our patients have elected to put a card on file in our software system that we have been authorized by them to charge after the appointment to be able to just so it minimizes how many times they have to talk to us on the phone. So some of them just prefer that method and just say, hey, just charge the card after the appointment for the appropriate copay or deductible. And so that's how we've been doing it.
Yeah, I'll just add, you know, a couple of things that we learned. One is having a very close and ongoing conversations with our insurance providers and our payers. You know, a lot of the larger providers will follow CMS and Medicare, Medicaid. You know, I see one of the questions is, what's it going to look like post-COVID? And that's a great question. I don't know if we have really a good answer. We're hoping that it sticks and it stays. I think some of that will be driven by the demand, you know, the patient's demand and the provider's demand. I think a lot of that conversation will be driven by that. So I think having those kind of open dialogues with our payers to say, hey, here's what our patients are asking for, here's what our providers are needing, has been helpful for us. The other big thing that that popped up on us is when I don't know how many of the providers are at home providing services, but that's one of the things that was a big surprise for some of our payers, with the provider's home being kind of designated as a location for them to provide services from. And so that's something that caught us early on that we you know, weren't necessarily prepared to figure out. But we have, because a lot of our providers are wanting to be able to connect from home as well if they can't be in the office. So a couple of things, just kind of that ongoing dialogue with payers, and things, something like where are the providers actually located at as well, for some of our learnings.
And Jason, thanks for those comments. And I want to pick up as well, not in the second, but in the third session, when we talk about the future, like what is the future, post-COVID, we're actually going to have a representative from a payer kind of be there and share his thoughts about, because they don't know either, but they definitely have some thoughts and some ideas, I think, that will inform what Jason referred to as, how do we communicate with our payers, and what are the value add that we're learning, in that situation. I wanted to just quickly interject as well. This is kind of fits off of sort of this comment about insurance and sort of will they pay. There's this sort of dynamic that happens about does the client feel safe to come in person, on one hand, and on the other hand, and I could speak from a behavioral health standpoint, at least within Intermountain. On the other hand, what about those that don't have the technology? And I think there were some comments about that, but specific to Intermountain, I can say that across the board, regardless of whether or not technology is available, the in-person is always available. And so what we talk to our families about and our patients is really what are the steps that we're putting into place to mitigate the risks. What are our check-in processes when we actually walk in, our visitor policies and those sorts of things. So we try to educate the individual and the families so that they're really, as best as we can, to prevent any barriers. So certainly technology, and that also goes within the behavioral health space. We still offer face-to-face interactions if the technology strategies just don't seem to work or aren't particularly effective for the patients that we're serving. So I wanted to address that. And I don't know if others have any other elements they want to share, particularly about that fear of coming back and how you all have tried to manage that when you are doing more face-to-face.
I think our approach has been the same as yours, Tamara, or as Intermountain's. I think there's been a whole lot of education and a whole lot of consultation with the state health department and Intermountain Health and the University of Utah healthcare system, and working with all of those teams to validate kind of what initially was just a good gut feel on what seemed to make sense, as we were jumping into all of this and didn't know exactly how things were going to turnout. And so I think that community collaboration has been super, super helpful. And then making sure that we have transparent communication. I mean, we've got meetings daily with all of our clients that can join available so we can update them on processes. We've got emergency management meetings with our teams every single day so that they are up to date on any changes that are happening within the organization. And we're just really, really leaning into the over communication. And when we're working with family members, particularly when their loved ones in residential care, whether it's an adolescent in our youth program or a shared custody situation in our parents and children's program, there's been a lot of communication about safety measures with those family members as well, so that they know that really coming into care and the precautions that we're using in care in a lot of situations is a much safer environment than the rest of our community is in, and certainly a safer environment than where a lot of our substance using clients are coming from, and in terms of the exposure that poses. So.
Thank you, Christina.
Something that I just would chip in here real quick. You know, we've also been dealing with the contingencies of the opposite, which are, you know, clients who are really, really ready to get back to normal. And then kind of like how are we communicating, you know, with folks that we're not quite there yet. You know, that by itself has been, you know, it's a separate challenge in all of this. And in the midst of it, you know, there's just been a lot of relational management, you know, with, you know, internally with staff, with clients, externally with stakeholders and community partners, because not everybody's on the same page, you know, with where we're at here. And so, you know, I think many people, you know, I've said they've kind of like staked their flags in the issue on either side, you know, some time ago. And so continuing to, you know, be flexible as an organization to work to accommodate, try and better accommodate those who are wanting, you know, more in-person services versus those who aren't ready for it. I mean, that's, you know, separate from the access issue. It's, you know, issue of perhaps preference. You know, but it's been difficult to navigate for us as an entity, because, you know, we remain on a higher level of restriction than, you know, most other, you know, places, at least here in the county. And so this, you know, kind of a separate talking point perhaps, but, you know, in doing all of this, it's been a huge consideration to think about, like, how are we communicating this in a way that, you know, again, continues to preserve confidentiality, and, you know, isn't just sort of like broadcasting, you know, participation in treatment. And there have definitely been challenges that way. I mean, we've seen a lot of success in, you know, the measures we have taken, and those measures have not always been met with open arms.
Makes a lot of sense. I think what's been really interesting, and this is kind of a comment, and then I can comment to this, but I'm curious about the panel, if they've seen any changes as a result to the really, really rapid transformation, not just with the technology, but that kind of overlaying the anxieties related to COVID and those sorts of things. Is anybody seeing kind of within their areas, and I can speak kind of from a surveillance perspective, but is anybody seeing any changes with regards to substance relapse, increased rates of relapse, or increased rates of suicidal ideation?
Yes. Yes. I mean, aside from the folks that we have contact with on a daily basis, you know, there's also alumni and, you know, folks that are out in the community that, you know, we hear about through the grapevine. And I personally believe that there's what I've kind of called it a tsunami of substance use disorder treatment need that's building right now. And there are a lot of folks who, you know, even with, you know, 1, 3, 5, 7 years of sobriety, have fallen off the wagon. And so, you know, we've done what we can to maintain contact with those folks and we've seen people who are wanting to re-engage in services. I think we've certainly seen a higher rate of decompensation of mental health disorders. I mean, that's definitely been a thing. And I think just even speaking, plainly about, the effects of all of this on staff as well. I mean, we've seen, a tremendous amount of distress due to, home living situations. We know that there have been reported, increases in domestic violence incidences in the community. I mean, there's so much effect here that is creating treatment need, even just outside the substance use disorder treatment world. But I mean, suffice it to say, yes, I mean, we've seen huge increases in recurrence, relapse behavior, mental health decompensation, serious mental illnesses, rearing up again. So
Great. Thanks, Jared. Appreciate that. Oh, Christina?
Sorry, we've seen the same thing. And I think if we look at isolation as a tall tale sign of a consequence, one of the first things you see when someone's struggling with substance use again, or when they're struggling with their mental health, the profound social isolation that we're all facing right now, even in spite of access to, virtual treatment or in-person treatment, everything that was normal is now kind of wiped away. And I think that is going to have some extremely profound impacts on our society for a very long time. For those of us who have young children or even older children, I mean, this absolutely qualifies as an ACE event for all of our kiddos. And I think being able to be mindful of that, and when we talk about funding and those types of things, that this is the very beginning of what is going to be a very long battle. So
well said.
Well said. Yes, I agree. And it kind of, as we're sort of evolving in this space, and I'm curious about what other organizations, within within the panel are thinking about, is as our environment begins to open up from a business perspective, how are you all thinking about sort of, the steps or the mechanisms to return some of the staff that are working remotely back to the office?
So I think that what we've been discussing is we are also following the CDC and OSHA guidelines for in-office appointments. And so we're hoping to kind of create more of a hybrid, and I'm really hoping that'll work out with insurance companies. We would like to still offer telehealth for those who are high risk or are not comfortable with doing in-person appointments. And for those who are just waiting to get back in person, we're hoping to stagger when our therapists are in the office so we don't have as many in the office at a time. Maybe we'll have them rotate which days they're doing telehealth at home and which days they're in the office seeing people. So we're kind of looking at more of hopefully a hybrid opportunity. And so we're kind of anxious to see what the insurance companies say. We're watching them if they're offering an extension on continuing with telehealth options. We are hoping to accept those so that we can still offer for both clients' needs, so whether they want to do telehealth or in person.
Yeah, I would just second what Stacy just said. And I mean, really, that's a big opportunity, I think, here is how do we augment what used to be our normal practice? How do we augment that with a virtual or telehealth option for both our patients and also our providers? And so we're also looking at really kind of what that hybrid approach and how we can kind of keep that going forward as well.
Thank you, Jason. I appreciate that. That's great feedback. Something quickly that I'll add, and then I'll kind of end with a kind of a final question. To really, because we are learning at such a rapid pace, just as the participants that are listening in and engaging in this conversation, for which we really appreciate the questions that are coming in. Very, very, very helpful, and I think really timely. Just a brief comment about the returning to the office. One of the things that we did was we kind of organized ourselves in terms of kind of the red, orange, yellow, and green, and really said, okay, what are the circumstances that we would lead us to kind of changing a little bit? And so how are we going to find that balance between kind of opening, providing more opportunities, some different opportunities, and enhancing some of the safety areas that we're trying to do when it comes to safety for people that are coming in physically, as well as sort of identifying what happens if it starts to retract and go backwards. And so how are we going to manage that in either direction? So we're trying to come up with some strategies there, but we're also going to learn from what works and what doesn't. And so we're trying to think ahead about what things are going to look like when they are, quote, green, and what does that actually mean? But what I am really interested in, there was a question that was raised that I think is really timely, and I want to just kind of in a short kind of succinct fashion, because we've got a little limited time here. What do you all see with sort of the potential, as where you stand now, what are the potential improvements with telehealth? I heard kind of the idea of it would be wonderful to think about hybrid. I'm thinking about a hybrid kind of strategy moving forward for different populations. Any other thoughts that your organizations have kind of been thinking about in terms of improvements with telehealth?
I'll just say quickly that a number of our providers have kind of reevaluated how they're practicing and providing care, and can they provide more frequent touch points with patients between those inpatient visits? I think that's a big opportunity in terms of looking at access and also the number of times that a provider is able to meet with their patients. And so across the board, I think that's been one of, I think, the opportunities that our clinicians have really looked at, and how they can adjust the way they're providing services now and integrate more of that telehealth component. And then really looking at outcomes and saying, what is the impact? So if I see a patient every 3 months, but I have a telehealth visit in the middle there, am I seeing a better outcome, and are the patients doing better? And so those are some of the things we're looking at, and then how we're looking at evaluating that, I think, going forward. So I think that's a big one for us.
Yeah, that makes a lot of sense. And from a behavioral health standpoint and working with children, I'm getting a lot of feedback from our providers about really thinking about, like, for some populations, it has been an enormous benefit to be operating, just as the example that was given. And so I think, to Jason's point, making sure that we understand, like, what is the impact, and then that conversation that we end up having with payers moving forward, because the value add to this in terms of impacting care is going to benefit everybody. And so how we think about that moving forward and how we're thoughtful about that as providers in the system, I think, are going to be incredibly important moving forward. I wanted just to quickly just share, as we're kind of in the last few minutes here, I want to, first of all, thank all of you that have participated and really had a very, very engaging conversation, and really kind of, I think, helped us understand some of the challenges that all of you are sort of working through. And hopefully you've had an opportunity to learn a little bit about some of the things that we're all kind of working through as we're learning some of the do's and don'ts of this work. For those that we weren't able to get to your questions, we're going to still have an opportunity to try to loop back with you to make sure. So we've kind of been monitoring some of those that we haven't quite addressed, and so we'll try to do that as well. And I also want to encourage each of you will get a survey with some questions to get your CEUs, but equally important to that, we're very, very eager. If you could just take a couple minutes and jot down feedback. We're very, very interested in your thoughts about having this type of panel and having this kind of dialogue as we're all learning how to do these sort of presentations as well. So your feedback would be incredibly valuable. Again, thank everyone for their comments and feedback, and the panelists as well for your insights and your learnings as well. I think as we move forward, this is going to be a really, I think, overall a wonderful opportunity for us to all learn collectively And based on your feedback, we're also interested in having this continue to be an ongoing conversation, because I think collectively we can learn a lot more from our experiences from looking at a large organization like an Intermountain Healthcare to medium and smaller nonprofit organizations as we try to navigate and learn from each other. So with that, please enjoy the rest of your afternoon. And thanks again for your time and participation.
Thanks, everyone.
Thank you, everybody.